Hello and welcome. This is Dr. Rockhold, and this will be the first of three segments on migraine pharmacotherapy. The image that you see overlaying the landscape in this slide is intended to be a depiction of something called scintillating scotoma. This is a frequent optical manifestation of migraine in patients who suffer from migraine with aura. And migraine with aura is one of the two major types of migraine whose treatment we will be discussing in these lectures. Overall, migraine disorders remain challenging. The etiology is still uncertain, the diagnosis can be difficult, and drug therapy has been, as is often, less than fully effective, unfortunately. As we go forward, I'll ask you to focus on the concept that the pharmacotherapy of migraine, if and when it's effective, can actually improve your patient's quality of life and reduce the significant migraine-associated costs to society. Furthermore, migraine attacks can either be acutely terminated or prevented by drug treatment. Our current understanding of migraine neuropathophysiology suggests that there are specific targets for the drugs that we're using. While certain serotonin receptor agonists can be beneficial in terminating acute attacks, and other classes of drugs can be beneficial for preventing or terminating migraine episodes, overall, we have to say that the effectiveness of pharmacotherapy remains less than optimal. On the bright side, the recent introduction of calcitonin gene-related peptide, or CGRP inhibitors, may offer significant new therapeutic options. The next couple of slides will introduce a few key points about the course of the disease of migraine that are relevant to the use of drugs to treat the disease process. So currently, about 36 million Americans, including children, suffer from migraine. The average overall in the United States is about 14.1%. That's a 3-month incidence rate. Developmentally, the incidence of migraine rises during adolescence, peaks at midlife, and then declines in later years. It's important to recognize that the incidence in adult women is 2 to 3 times that of men. The two most common disease codes for migraine are migraine itself, which is also referred to as the common migraine, and migraine with aura, the classical migraine. About 70 to 80% of sufferers have a family history of migraine, so there is a genetic component. But in an individual, specific conditions will act as triggers to precipitate an acute attack. Menstrual-related migraines are reported in about 2/3 of women with migraines, and other well-known triggers include stress and foods such as red wine, aged cheeses, and monosodium glutamate. The time course of a migraine attack typically shows a prodrome phase with symptoms that precede the onset of pain. Some migraineurs experience aura, in which the most common symptoms are visual, with blind spots in the visual field that grow progressively and are often outlined by shimmering or scintillating scotomas. Migraine with aura may be related to a brain phenomenon called cortical spreading depression, in which a slow-moving band of neuronal depolarization can be traced starting in the visual cortex and moving anteriorly. The primary symptom is episodic, recurring, moderate to severe headache pain, which tends to be unilateral, often has a throbbing character, and is intensified by physical activity. Nausea and vomiting, as well as sensitization to sound, phonophobia, and to light, photophobia, are common. It is a debilitating disease. The acronym SULTANs for, and you must have at least 2 of these, severe, unilateral, throbbing, activity worsens, and either nausea or vomiting or sensitivity to light and sound, is a useful mechanism for making a diagnosis. The duration of attacks can run from 4 to 72 hours. Those individuals who have frequent and debilitating attacks are termed migraineurs, and roughly 2/3 of all migraineurs will develop cutaneous allodynia, a situation where normally innocuous sensations, such as the pressure of clothing on skin, will become acutely painful. And once in a migraine attack, once begun, headache pain and related symptoms rise to a crescendo and then subside. A post-dromic phase of fatigue and lassitude is common before full recovery. To interrupt a migraine attack that has begun, selective serotonin 5-HT1 receptor agonists, the triptans, are currently the most commonly used drugs. However, it's important to recognize that these agents become significantly more effective if they're administered as soon as possible in the migraine sequence. We'll talk more about CGRP receptor antagonists later. It has to be stated that the etiology of migraine remains poorly understood. However, we currently believe a few key points. First, migraine is not a disease of the circulatory system. While vascular changes are involved, it is a disease characterized by altered brain excitability, and it can become a chronic syndrome. Second, a key component is trigeminovascular innervation of meningeal blood vessels. Migrainous pain is related to sensitization of these neurons, which results in the release of pain-inducing neurotransmitters on meningeal arteries, including particularly calcitonin gene-related peptide, CGRP, but also substance P, neurokinin A, and nitric oxide, and perhaps others. These result in perivascular inflammation and dilation of meningeal vessels. Once they have been sensitized, these first-order neurons bombard the trigeminal nucleus with input, which is then transmitted through second-order pain-related fibers up to the thalamus and to brainstem centers that mediate nausea, vomiting, and vertigo. Finally, third-order thalamocortical neurons can be entrained to lead to a higher level of sensitivity. And this results in chronicity of migraine attacks and, in some cases, the development of cutaneous allodynia. The source of this initial trigeminovascular activation remains uncertain, but it may relate to the phenomenon of cortical spreading depression. We do suspect that CSD accounts for visual symptoms of migraine aura. With respect to serotonin, receptors are found on meningeal blood vessels where they mediate vasoconstriction, and on trigeminal nerve terminals where they inhibit neurotransmitter release. The hypothesis that chronic depletion of serotonin leads to the development of migraines has been suggested but remains a hypothesis. And this brings us to pharmacotherapy. Two main pathways to consider. Migraine attacks can be interrupted or aborted during an attack, or they can be prevented by prophylactic use of drugs, or both. In acute attacks of mild to moderate severity, simple analgesics like an NSAID or acetaminophen can be sufficient to manage the pain. Caffeine will aid absorption of these analgesics and enhance analgesic actions. When nausea, vomiting, and/or diarrhea are significant, antiemetics should be added. Severe attacks require a different set of drugs. They can be treated by selective serotonin 5-HT1 receptor agonists, the triptans, or lasmiditan, and there are two CGRP receptor antagonists, rimegepant and ubrogepant, which have been approved for the use in acute attacks. In addition to that, in more refractory migraine attacks, we may bring out other serotonin receptor agonists, non-selective serotonin receptor agonists, the ergot alkaloids. And ultimately, it may be necessary to use opioids to control the pain, although increasingly that is a more distant option. When acute therapies fail, using prophylactic drug therapy to prevent attacks is considered. And we have a variety of drugs there. There are a number of CGRP blockers. The beta adrenoceptor antagonists are very commonly used as prophylactic agents. Certain calcium channel blockers, certain tricyclic antidepressants, a few anticonvulsants, and then a number of other agents like Butterbur or Botox have been used in prophylactic management of migraine disease. So, the take-home messages from this segment of the lecture are that migraine, while complex, tends to have predictable features within a patient. The etiology involves sensitization of trigeminovascular nerve terminals, and this leads to sensitization of central pain circuits, and serotonin depletion appears to be important in these processes. Drug therapy should first attempt to interrupt and relieve acute attacks, most often with the use of a triptan. When this is unsuccessful, prophylactic therapy with a beta blocker, a CGRP antagonist, or one of several other agents is typically applied. And again, we'll focus specifically on the newer CGRP antagonists and their evolving roles in the following lectures. Thank you.